that was a well done summarized case, the history, the flow, in trying to pick the salient things. And so I think you captured very well the history, because the presenting complaint was chest pain. You try to exhaust as much as you can the chest pain, but you know very well that chest pain has got you should use to approach, that is Socrates, site, onset, character, this and that. And it was well captured in terms of characterization. It was crashing, it was central, etc., radiation, aggravated by this, relieved by that. So that was captured. The second thing is when you come to chest pain, previously we used to classify as typical, atypical, so on and so forth. But now these days, there's a guideline that was just released last year. It has been revised as just cardiac and non-cardiac. That's how we distinguish chest pain. So in the process also, when you are trying to capture chest pain, as much as you characterize the cardiac chest pain, you must also pick the life-threatening causes of chest pain. And there are around 4 or 5 of them. One of them, of course, is what you have discussed, myocardial infarction, which I'll tell you whether to use the right word, whether it's myocardial infarction or another word. But for now, let's say cardiac, acute coronary syndrome, esophageal rupture, aortic dissection, pulmonary embolism, and pneumothorax. These 5 you must pick in your history because they are life-threatening. If they are not attended to immediately, they may kill the patient. The next thing you discussed, of course, is the risk factors. You are trying to find out, already your mind is set towards a heart attack. And because we know the causes of heart attack, you try to elicit from the history the risk factors, the so-called traditional risk factors, hypertension, diabetes, age, gender, family history, smoking, so on and so forth. Then we have got the non-traditional, or what you call the novel cardiovascular risk factors, which you may not be able to take in the history. But overall, if I summarize the history, whenever a patient presents with a complaint, the first thing you exhaust is that complaint. Like in this case was chest pain. So you exhaust chest pain, site, onset, character, this and that. The second paragraph should contain symptoms related to that particular system. In this case, we are thinking of cardiovascular, probably. So because we think caused by cardiovascular, you ask the patient symptoms related to that system, which you brought out very well: palpitation, paroxysmal nocturnal dyspnea, orthopnea, etc., etc., etc. The third paragraph will contain history of symptoms of systems related to the presenting complaint. In this case, the respiratory system. Because the respiratory system, the gastrointestinal system, and the musculoskeletal system can present with chest pain. So you try to exhaust. And somehow you also touched on it, which was commendable. Then, of course, after that, you go into the systemic inquiry, which was well done. You summarize the patient, you went to the physical examination. The physical examination, the general exam, you captured very well how the patient is well nourished, seated, respiratory distress, this and that. Then you have to start with the system you're thinking of most, in this case, cardiovascular system. The only problem I had with that was you added tachypnea in cardiovascular system examination. Tachypnea is a respiratory system finding. It's not a cardiovascular system finding. And then, of course, you complete your system, cardiovascular, respiratory, per abdomen, and CNS, which was commendably done. Now, when it comes to conclusion and impression, the best thing to say is that you are suspecting, or your first impression, you don't say myocardial infarction. Myocardial infarction, it's a pathologic diagnosis. So the right word to use is acute coronary syndrome. So in this patient, what I will say is I'm thinking that the cause of this pain is cardiac, most likely acute coronary syndrome with a differential diagnosis of, then now you can start writing acute pericarditis, PE is a possibility, pneumonia is a possibility. This is a patient who ingested alcohol and he was vomiting a lot. What is the possibility that was caused by esophageal rupture? It's very possible. Could it have been caused by esophageal tear? It's very possible. So on and so forth. So the impression is my acute coronary syndrome. You can only use the word myocardial infarction if you have evidence to show that this patient has actually suffered heart attack. So in summary, your history of physical examination, the flow was very good, but try to be, especially the impression, don't be too specific. For example, you cannot just say, this patient has iron deficiency anemia. Straight, you can't. But what you'll rather say is, this patient has got anemia, most likely secondary to iron deficiency, with a differential diagnosis of this and this and that and that. Because all you are basing your impression is just the history and the physical examination. You don't have anything else in your hand. And a young man like this, definitely acute coronary syndrome is a possibility. He has no any risk factor. He doesn't smoke, no hypertension, no diabetes, etc. Can he get acute coronary syndrome? Of course he can. Pericarditis is a very important differential, and I like the way you put it, but because I've seen the lab result, maybe the discussant will tell us through, but because the troponin was elevated, I will consider myopericarditis. And then probably the discussant will take us through the ECG and the lab result, hopefully, because there are ECG findings I found that were positive. But overall, it's well commended in terms of presentation, the history and the flow and everything. But when you're making an impression, don't be too specific. Don't point the finger by saying this is MI. You have to have a general approach. You say most likely it's acute coronary syndrome, and my differentials are the following, and therefore I will order for the following test. Now, when it comes to the labs, when it comes to the laboratory results, you don't just write haphazardly, full hemogram, UECs, echo, ECG. You must be very focused. You say why you are saying, why did you ask? Why do you have to ask for UECs? You have to prioritize. Like in this case, was I'm just giving an example, full hemogram necessary? I don't know. Troponin, was it necessary? Probably. ECG, echo, how do you prioritize? Is an echo a must in this patient? Maybe. So when you are giving your investigative management, you should do it in such a way that it should be able to answer the question at hand. So those are my few comments on the history and physical exam, but well done. So I hand over to the discussant.
Zuhra?
Assalamu alaikum. Can you hear me?
Yes, we can.
So today we're doing acute coronary syndrome. Are the slides moving?
Yes, you can see your slides.
They're not moving. Just a minute. So you can see them. So ischemic heart disease Ischemic heart disease is a group of diseases in which there is inadequate supply of oxygen to a portion of the myocardium. So this results due to an imbalance between oxygen demand and oxygen supply. Cases where the oxygen demand is higher include when the myocardium is hypertrophied, or when there is hypotension, or when the patient is tachycardic, and when there is less oxygen supply, is mainly because there is occlusion to a coronary vessel. So it might be an aroma, an embolus, or a stenosis of a coronary artery. So normally the demand is higher than the supply. That's when ischemia happens. So 90% of ischemic heart diseases are due to coronary atherosclerosis. Other causes, the other 10% could be due to vasospasm, emboli, it could be congenital or inflammatory conditions. So the coronary arteries involved in atherosclerosis mainly are the left anterior descending, which atherosclerosis happens in 40 to 50% of the cases. It's a branch of the left coronary artery, and it supplies blood through a section of the ventricular septum, the apex, and the anterior portion of the left ventricle. Then the next artery is the right coronary artery, which 30 to 40% of cases of atherosclerosis, and it supplies the right atrium, the right ventricle, and a portion of the left ventricle. Then the left circumflex, about 10 to 20% of atherosclerosis, and this is a branch of the left anterior descending, and it supplies the posterolateral portion of the left ventricle. So clinically, ischemic heart disease is divided into myocardial infarction, angina pectoris, chronic ischemic heart disease with heart failure, and sudden cardiac death. So the risk factors for atherosclerosis could either be modifiable or non-modifiable. So the modifiable risk factors include cigarette smoking, heavy alcohol consumption, obesity, that's a BMI of more than 30, hypertension, dyslipidemia, DM, lack of exercise, diet rich in fatty foods, blood coagulation factors where there's increase in fibrinogen, homocystinemia, and elevated CRP levels. The non-modifiable factors include age, because it's higher in males, in the elderly, and for sex, atherosclerosis happens more oftenly in males, and family history. So for the pathophysiology of atherosclerosis, it occurs through these events. So first, there's an endothelial injury. Whenever there's an injury, either because there's a hemodynamic disturbance or the risk factors like cigarette smoking come into play, this causes the injury. Now, this is what causes leukocytes, especially the monocytes, to migrate, and there is increase in vascular permeability. Now, when there is increase in vascular permeability, the monocytes and the T lymphocytes migrate, and the monocytes transform into macrophages. So, just a minute. So when the monocytes have been activated into macrophages, the lipoproteins and the lipids also accumulate in the intima of vessels. Now, the free radicals, and now the macrophages engulf this LDL, form the foam cells. Now, after the foam cells have been formed, others may be apoptotic. Now, this stimulates release of cytokines and chemokines, and now growth factors are released. Now, these growth factors stimulate the migration of the smooth cells, the smooth muscle cells into the intima, and the growth factors still stimulate these smooth muscle cells to proliferate the intima, producing the extracellular matrix. Now, when the extracellular matrix production has happened, now there is accumulation of lipids both intracellularly and extracellularly, forming the atheroma. So the clinical syndrome of sclerosis includes angina, acute coronary syndrome, prismatic angina, and sudden cardiac death. So acute coronary syndrome is a spectrum of clinical presentation ranging from ST elevation, myocardial infarction, or ST elevation, cardiac infection, and unstable angina. So for the stable angina, it occurs when there is partial occlusion of the vessels, about 70% of the coronary vessels. The atherosclerotic plaque is stable and does not rupture. That's the main difference between stable angina and acute coronary syndrome, that the fibrous cup lining the plaque is stable, so it doesn't rupture. So pain occurs when there is increased demand of physical activity. So this one is related with some exertion. That's what causes the anginal pain. Stable is reversed or nitroglycerin. So for presentral angina, due to coronary constriction and has typical anginal signs, but is increased, and its risk factors include smoking, alcohol use, and use of triptans. So the pathogenesis of acute coronary syndrome, we said that there's partial occlusion of the vessels. So when there is an acute change, convert occlusive atherosclerotic plaque to produce sudden ischemia. So the plaque ruptures, exposing the highly thrombogenic material, which may undergo hemorrhage into the central core of the plaque, thus causing sudden occlusion of the lumen. After that, the platelets are there to the site. Platelets are activated and they aggregate further occluding the lumen. Then there is activation. There is a release of inflammatory cells and mediators which cause vasospasm. And after that, tissue factor is released at the site of the acute plaque change, and this activates the coagulation pathway, increases the size of bones. Now this leads to complete of the vessel within minutes by the thrombus. Then there is now myocardial necrosis, where there is ischemic coagulative necrosis at the area supplied by the specific coronary artery. So for unstable angina, the fibrous cup is unstable and ruptures, exposing the fatty material. So the platelets adhere to it, they stick to form a thrombus. They cause occlusion of about 90%, and it causes ischemia. So this anginal pain occurs at rest. For NSTEMI, still the same as unstable angina, the fibrous cup is unstable and it ruptures, it exposes about 90%, but here blood flow is reduced in the cells such that cells die, causing infarction. So for unstable angina, it's ischemia, but for NSTEMI, there is infarction. And there is subendocardial infarction, which occurs in inner 1/3 to 1/2 of the myocardium. So some of the myocardium is spared in NSTEMI. For STEMI, there is complete occlusion by the thrombus. So 100% of the coronary vessel, there is completely no blood flow, and there is complete loss of supply of oxygen to the entire myocardium. So it's transmural. So ischemic necrosis of the entire thickness of the myocardium. So this is a diagram to show the differences. So stable angina, it's effort related. Whenever there's increased demand, there is partial occlusion. So whenever there is increased demand, now that's when anginal pain develops. So the ECG is normal and the troponin levels are normal. For these 2, 3, and 4 are the acute coronary syndrome. So for unstable angina, the plaque ruptures and the thrombus forms. So there is partial occlusion, and the pain occurs at rest and progresses rapidly over a short period of time. So this is what causes supply ischemia, but no infarct. And the troponins are normal. For NSTEMI, the difference between unstable angina and NSTEMI is that both of them, the plaque ruptures and there is partial occlusion. But for here, it's not ischemia, it's an infarction to the subendocardial myocardium. So, and the troponins here are elevated, unlike for unstable angina, the troponins are normal. So for STEMI, there is complete occlusion by the thrombus. So it's occurs at rest and it's reflected by ECG. So ST elevation, so there is hyperacuity waves or ST elevation, and the troponins are also elevated. So the symptoms, how does a patient present? A patient with acute coronary syndrome. So there is usually retrosternal chest pain. So the patient may describe it as squeezing or a pressure or a burning sensation across the precordium, which may radiate to the neck, the shoulder, the jaw, the back, or the upper abdomen, or either arms. The patient might have palpitations. There is anxiety and diaphoresis and feeling of impending doom. This is because the sympathetic nervous system is stimulated, and there is nausea and vomiting because the vagal axis is also stimulated. Now, some patients may present asymptomatically, and this is called silent MI. They'll have a myocardial infarction but no chest pain, and this occurs mainly in elderly and the diabetic. So on physical examination, on a patient with acute coronary syndrome, what do you see? So the patient is distressed, and the patient is diaphoretic or maybe cyanose, and he's anxious. There is low thready pulse. The blood pressure may be increased or decreased, and you'll hear the fourth heart sound as 4 sometimes. And there'll be signs of heart failure, that is the GVP will be distended. You'll hear basal crepitations because of pulmonary edema, and S3 will be had. Then there'll be a pansystolic murmur. As I said, some patients may present asymptomatically. So investigations. So you do a full hemogram, the basic test, you do full hemogram, you do the biochemistry, the lipid profile to monitor the HDL and the LDL, you take the sugar levels, you check the UACs, you can do a chest X-ray, and you may do cardiac catheterization for reperfusion and stress testing. Now the diagnostic investigations, these are the gold standards. So ECG is the main one used. So for STEMI, there is ST elevation as by the name. There is hyperacute T waves or left bundle branch block in hours. There's T wave inversion and pathology Q waves of hours to days. For STEMI, there's ST depression, T wave inversion, but unlike STEMI, it does not progress to Q waves. So Q waves, pathology Q waves are mainly seen in STEMI. So this is a diagram showing this is a normal ECG, showing the P wave, the QRS complex, and how the ST segment is supposed to look like. For STEMI, the ST is elevated, as you can see. For NSTEMI, there's ST depression, and for both, there is T wave inversion. So the next diagnostic investigation that is done is biomarkers. So the biomarkers include myoglobin, creatine kinase, and troponin. So in an infarction, the first, as you can see here, the first biomarker to rise is myoglobin. So myoglobin is an oxygen-carrying respiratory protein. It's found in both skeletal muscles and cardiac muscles. So, and it is the earliest marker. It rises in as you can see, it rises in 1 to 2 hours, peaks at 8 to 10 hours, and it returns to baseline in about 2 days. But it's not specific, so it's not a So for creatine kinase, and the isozyme used here is CKMB, because that's the one found in cardiac muscle. So CKMB is the next to rise. It rises in 3 to 12 hours, peaks at 24 hours, and returns to baseline for 8 to 72 hours. Then the next is troponin. Troponin is the most sensitive and specific marker of myocardial infarction. So there's 2 types, troponin T and I. They start rising in 3 to 12 hours after the infarct. They peak at 24 to 48 hours and return to baseline. Troponin I returns to baseline after a week, and troponin T returns to baseline after 2 weeks. So as I said, creatine kinase, 3 isoenzymes, CKMM in skeletal muscle, CKMB in cardiac muscle, and CKBB in the brain. So in an infarction, both the total creatine kinase and CKMB that's on the cardiac muscle are raised. So to get a clearer results, you do the ratio of CKMB to creatine kinase. And if the ratio is increased from 10 to 30%, then you would know that's a myocardial infarction. CKMB is also used to diagnose reinfarction. So as we said here, that troponins return to baseline after a week or 2 weeks, 2 weeks, 14 days. So they do not show us if there's a reinfarction, but creatine kinase returns to baseline after 72 hours. So they can be used to diagnose a reinfarction. So, but creatine kinase, as we said, it's non-specific because it can be raised in clinical settings like trauma, heavy exertion, and skeletal muscle disease. Then troponins, 3 subunits, troponin C, which binds to calcium ions, troponin I binds to actin and inhibits the actin-myosin interaction, troponin T binds to tropomyosin, attaching to the thin filaments. So the cardiac troponins are sensitive, cardiospecific, and provide prognostic information for patients with acute coronary syndrome. So as I said, myoglobin is not cardiospecific. There's a new biomarker that is brain natriuretic peptide, BNP, precursor that is synthesized into proBNP. So this proBNP is measured to detect or rule out heart failure. So if this test has a high negative predictive value, meaning that if you do a test on a patient and the proBNP is negative, the negative result rules out disease more than a positive result rules in the disease. So the BNP is a predictor of death and cardiovascular events in a person without a previous cardiac dysfunction diagnosis. So echo is the other diagnostic modality. So regional wall motion abnormalities can be identified with this modality, and also helps in identifying the extent of infarction and assessing the overall functions of the left and the right ventricles. In addition, the echo can identify complications such as acute mitral regurg, left ventricular rupture, and pericardial effusion. So myocardial perfusion imaging, that's where they use radionuclide imaging, has favorable and diagnostic prognostic value in emergent setting with an excellent early sensitivity in detection of acute MI. You can also do angiography in high-risk patients who present with cardiogenic shock, intractable angina, and severe pulmonary congestion. So the differentials, as Dr. Hassan has said, a patient presenting with could have the other life-threatening conditions like pneumothorax, pulmonary embolism, esophageal rupture or tear. There could also be aortic stenosis. Those are the other differentials. But there are also other differentials for the ECG changes, that is ST segments and T waves have other causes, for example, left ventricular aneurysm, pericarditis, prismental angina. This is actually very important because for prismental angina, if you confuse a patient with prismental angina and a patient with stable angina and give them drugs for stable angina, for prismental, the aspirin and beta blockers are contraindicated, so you might kill the patient thinking they have stable angina and they have prismental angina. And there is patients who are on drug therapy like tricyclic antidepressants and phenanthrene and with Parkinson-White syndrome. So for treatment and management, to all patients, you give MONA, that is morphine. Morphine will act as an analgesic and relieve the pain and the anxiety of the patient. Oxygen, you're giving oxygen to the ischemic areas of the myocardium. Nitroglycerin, the nitrate like nitroglycerin, which acts as a vasodilator, and aspirin, which is a COX-2 inhibitor, so which inhibits thromboxane formation, so inhibits platelet aggregation. So you do a serial ECG. After you do MONA, you give MONA to patients, you do an ECG, and you assess the cardiac markers. So if there's an ST elevation, STEMI, you do a reperfusion therapy. That is, you do PCI, percutaneous coronary intervention, where you dilate the the artery stenosis by introducing an inflatable balloon. Then there is thrombolytic therapy. It's in within 4 hours. You give streptokinase. And now these ones are for life. Idostatins, beta blockers, ACE inhibitors, and aspirin. And then you give clopidogrel for about a month. If it's NSTEMI, you give heparin. And after you give MONA, that is, you give heparin, then you assess the cardiovascular risk according to the GRACE score. So the GRACE score consists of risk factors. And if, for example, patients with high risk include patients with diabetes, ST depression, high cardiac markers, and persistent or recurrent ischemia. So this is a diagram showing the total score. If it's less than 100, it's low risk patients. In hospital death, less than 1%. On a 1 to 170 is medium risk patients, and more than 171 are high risk patients and have hospital deaths of more than 9%. So if the GRACE score is low and moderate, you give heparin only. If the GRACE score is high, give heparin and tirofiban and do angiography within 4 days. Then alternatively, just like STEMI, you give these discharge medications, aspirin, beta blockers, ACE inhibitors, statins. And clopidogrel is given in moderate and high risk GRACE score for about a year. So for NSTEMI, thrombolytics are not used, they're contraindicated. So this is a diagram showing just what I just said. If there's an acute coronary syndrome suspected, after you do MONA, you give MONA to the patient, you take a 12-lead ECG, and if there's no ST elevation, but the troponin test is positive, that's an NSTEMI, and you give medical management. So you aim for percutaneous coronary intervention within 72 hours in patients with a 6-month mortality rate of more than 3%. If the troponin is negative, then it's unstable angina. And if 12-lead ECG shows ST elevation or left bundle branch block, it's a STEMI. So you give the thrombolytic and the primary PCI. So the complications, finally, the complications of acute coronary syndrome. So the cardiogenic shock. When there is infarction, there is severe pump failure, especially in large infarcts, and this can lead to cardiac shock, cardiogenic shock, which can be fatal. Then there is arrhythmias. So whenever there is infarction, there is myocardial irritability and conduction disturbances, which leads to arrhythmias, for example, sinus bradycardia, AV block, ventricular fib, which is the most common cause of death, and partial or complete heart block. Then the other complication is pericarditis. So there are 2 types. Early pericarditis starts 1 to 2 days after the infarction, and it's because of spread of inflammation. And for late, which occurs about 2 to 3 weeks after the infarction, called restless syndrome, it's immunologically mediated. So it's caused by antigen-induced inflammatory response. The other complication is the mural thrombus. So whenever there is an infarction, there is an abnormal contractility of the myocardium, which leads to stasis of blood. So whenever there's stasis of blood, that favors the thrombi formation in the walls of the ventricles. Then we have the rupture of the chorda tendini. This is what leads to mitral regurgitation, and you hear the pansystolic murmurs. There's the rupture of the wall of the ventricle, which leads to cardiac tamponade. The rupture of the ventricles, it's because there is necrosis. So the walls of the ventricle become weaker and softer. So it's eventually ruptures, there's ventricular aneurysm. And then there is the rupture of the interventricular septum, leading to ventral septal defects. Now, whenever there is an infarction of the left ventricle, it may progress to the right ventricle. Now there is pooling of blood on the right side, the venous blood on the right side of the heart. Then now it will progress to late heart failure because of decompensation by the hypertrophied myocardium. Yeah, so I'm done. Thank you. Anyone with any question or clarifications? And Dr. Hassan, you may comment.
Yeah, first of all, I'm actually impressed. This is a very deep stuff. I wonder how long you have been going through. I really like your grasp of the anatomy, the pathophysiology especially, and the reasoning behind some of the complications, what leads to what. So well done. I think it is excellently summarized. You have taken the salient points and some few pointers. Number one, some few terminologies have changed. For example, these days we don't use stable angina. It has been changed to what you call chronic coronary syndrome, just the opposite of acute coronary syndrome. So ischemic heart disease, the presentation is either acute coronary syndrome, chronic coronary syndrome, sudden cardiac death, or ischemic cardiomyopathy. So those are the four presentations. The way a patient can present is in either of those four. So rather than dividing it into four categories, a patient can present either as ACS, CCS, what we used to call stable angina previously, ischemic cardiomyopathy, or sudden cardiac death. And the other thing is, when a patient presents you with chest pain, the first diagnosis you will make, as you rightly put it, is acute coronary syndrome. That's the word you use. And in your investigation, you put ECG as an alternative or later, but ECG is the most critical test you will do. Immediately the patient walks into the room, the first thing you're supposed to do is an ECG. So there's something called FMC, first medical contact. The patient, immediately they arrive at the accident emergency, they present with chest pain. One of the first tests you'll do is an ECG. So ECG is a priority and is up there top in the diagnostic approach to ACS. So when you do ECG, you get, depending on what you find on the ECG, for example, if there's ST segment elevation in two contiguous leads. For example, if my V1 has got an ST segment elevation, but V2, V3 doesn't have any ST segment elevation, then you can disregard. For us to consider it significant, it must appear the ST segment elevation in at least two contiguous leads. So when you see ST segment elevation in two contiguous leads, then you still use the word ST segment elevation acute coronary syndrome. We're not using the word MI still. If there is no ST segment elevation, but there's either T-wave inversion or ST segment depression, and you are highly suspicious of acute coronary syndrome, we call it non-ST segment elevation acute coronary syndrome. At that particular time, because your suspicion is very high for cardiac chest pain, you go ahead and institute the management as you're trying to take a small detailed history. When did the chest pain begin? What else are you feeling? If a patient has got chest pain, described as angina-like, crashing, central, etc., diaphoretic, vomiting, epigastric pain, female, diabetes, whatever, treat it as acute coronary syndrome until proven otherwise. So the first thing you do is, as you're taking history, you connect the patient to a patient monitor, you do your ECG, you're classified as either ST segment elevation or ST segment depression, or what you call the non-ST segment elevation acute coronary syndrome. At that particular time, you give your first treatment as you draw blood. So these things go hand in hand. And the treatment you're supposed to give, we don't give morphine anymore. So that MONA has changed. That nomenclature MONA has changed. We don't give morphine unless it is extremely, extremely, extremely necessary. If the patient has got continuing ongoing chest pain, you give other pain-killing agents. And the most important pain-killing agent is nitroglycerin. Of course, with a caveat that you look at the blood pressure, so that if the systolic blood pressure is less than 100, you cannot give nitroglycerin because it causes hypotension. Aspirin, it must be given and it must be chewed. And you give a very high dose, something like 300 milligrams. In Kenya, what we have is a 75 milligram tablet. So you give 4 tablets and you ask the patient to chew. Why are you chewing? So that it is even absorbed in the venous plexus under the tongue, so that you want to do maximal antiplatelet activity. You want to aggregate platelet activity. In addition to aspirin, you give other antiplatelets. You can give clopidogrel, but there are newer agents, which I think you should also know because that's what we are using these days. There's one called ticagrelor and one called prasugrel. So we prefer ticagrelor or prasugrel to clopidogrel. But if you don't have, you can still give them clopidogrel. So you load, that's called loading. You load the patient with dual antiplatelet therapy, aspirin plus another antiplatelet agent. At the same time, you give low molecular heparin. Because what we are trying to do is to break down that thrombus and prevent it from propagating. And the thrombus consists of 2 things, as you rightly said in the pathophysiology. There's platelet and there are coagulation factors involved, thrombin, etc. So that's why you're also using heparin, which is a thrombin inhibitor. On the other hand, you're using antiplatelets. So you are trying to maximize all kinds of things that can break down that clot. So I have given my painkiller if the patient is in pain. If there's not pain, don't give anything. So morphine is not supposed to be used unless it's necessary. I give my dual antiplatelet therapy, preferably to be chewed. Thereafter, I give my Clexane, low molecular weight heparin, or if you have unfractionated heparin, whichever. And you put the patient on a patient monitor. Why? Because you want to monitor for complications. As you rightly said, arrhythmias. The most important is, of course, arrhythmias. The other thing you'll do is you look for the saturations. If the oxygen saturation is not less than 90%, you don't give oxygen anymore. There's a recent study that was done, and it was shown that it's even harmful to give oxygen unnecessarily. The trend is every patient who comes unamwekea oxygen, but that is not done anymore. So all these things, as you are doing, you have already done your ECG and you have classified this patient as acute coronary syndrome. You fix a 2 large bore granula and you draw blood. And one of the blood you test for is cardiac enzymes. These days, we don't use any other enzyme. We only use cardiac troponin because, as you rightly said, it's highly specific and it's prognostic. However, CKMB can help you to diagnose reinfarction. For example, a patient came, the troponin, the CKMB are high. If the patient suffers another event while in the hospital, the best test is CKMB because a second rise means the patient's reinfarcting. But these days we use cardiac troponin and it's extremely, extremely important. Every laboratory hospital must have that. You also order for UECs. The reason is because if the patient turns out to be ST segment elevation, we want to take him to cath lab, we'll inject him with contrast. And contrast is causes kidney disease, nephropathy. So there's something called contrast-induced nephropathy. Another reason why we do UECs is when it comes to non-ST segment elevation acute coronary syndrome, the GRACE score you mentioned, one of the components is creatinine level. The higher the creatinine, the higher the score in the GRACE score. And I will mention a little bit what GRACE score is. So if a patient presents with features of acute coronary syndrome, the symptoms you have mentioned very well, the signs you have elicited very well, the sympathetic overdrive, but there are those patients who we call it atypical presentation. It does not necessarily mean silent MI, but they present atypically. How do they present? They present with dyspnea. They present with dyspepsia. They present with epigastric pain and gastritis features. This is called atypical presentation. And it happens in 3 people: diabetics, elderly, and female. So these 3 people, if they present with persistent vomiting and epigastric pain, just take an ECG. Be surprised to see what is causing the problem. So as you do all these things, the next thing you look at is the ECG. The ECG, as you rightly said, you have to do serial ECG. The reason is because the first ECG can be normal. The first changes that happen is a hyperacute T wave, which the differentials are very many. It could be caused by hyperkalemia, etc., etc. You repeat the ECG after another 10 minutes, and you'll see all those changes you have seen: hyperacute T wave, ST segment elevation, T wave inversion, ST segment depression, then Q wave evolution. That is what you call acute coronary syndrome evolution. I've got ST segment elevation. So the first three management, aspirin, clopidogrel, high dose atorvastatin or statin. If you're using atorvastatin, we give 8 milligrams. If you're using rosuvastatin, you use 40 milligrams because 40 milligrams of rosuvastatin is equivalent to 8 milligrams of atorvastatin. So after you have given your heparin, your atorvastatin, your aspirin and clopidogrel, these four is standard for all ACS, whether there is ST segment elevation or not. Now, thereafter, what will determine the next step depends on the ECG. If the ECG shows ST segment elevation, you have to do something called reperfusion therapy. You have to open that blocked vessel because, as you rightly said, the vessel is completely occluded. And we usually say time is muscle. The more time is wasted, the more muscles die. So how do you open it? You can either open mechanically, which is the preferred way, where you take the patient to cath lab, put a catheter inside, get the occluded artery. If there is a thrombus, you suck out. If there is no thrombus, there is just atherosclerotic plaque. You put a balloon, you dilate, you put a stent, and get out. That is called mechanical opening, which is now PCI, percutaneous coronary intervention, or what is called angioplasty. The second way of opening is by giving thrombolytic, the so-called clot busters. These are things that go straight into the coronary wherever there's a clot and they break down. Streptokinase was the first one that was discovered, but now these days we have got better ones which are well tolerated, which are highly fibrin specific. A very good example is tenecteplase, alteplase. There are very many, but the one which is mostly used in MI is tenecteplase. Because of ease of administration, you just give a bolus and that is it. If you don't have, you can use alteplase. It's usually given in the form of infusion. But now you don't give ST segment elevation, all of them thrombolytics. There is a cutoff. If the patient presents in less than 3 hours and you don't have a PCI facility, there is no cath lab, you give thrombolytic. If, for example, if it's after 3 hours, the maximum you can give is 12 hours. Anything after 12 hours, the thrombolytics will not help. After that, after you have done your aspirin, your clopidogrel, atorvastatin, Clexane, and depending on whether it's ST segment elevation or not, you have done either thrombolysis or not, you transfer the patient to a PCI capable facility. All the other medicines you mentioned, the beta blockers, the ACE inhibitors, aldactone, which you have not mentioned, we call them MRS, all of them must be started within 24 hours of acute coronary syndrome, regardless of whether it's ST segment elevation or not. Of course, what will lead you again is the vital signs, the heart rate, the blood pressure, so on and so forth. And you have drawn your blood, by the way. So the result have come back. If the troponin is elevated and there is ST segment elevation, this is when you use the word now STEMI. Until then, you are not allowed to use the word MI. You only use the word acute coronary syndrome. If on the other hand, there is ECG changes, but the troponin is normal, we call it unstable angina. If there is no ST segment elevation, there may be T wave inversion, etc., but the troponin is elevated, we call it NSTEMI. Now we use the word MI. Because there's troponin, troponin means the myocytes have died and blood has been released, troponin has been released into the circulation. While we use NST because there is no ST segment elevation. So that's how you classify. Now for NSTEMI and unstable angina, you don't do thrombolysis and you don't rush to cath lab. But they will still need angiography. Who will need angiography more urgent than the other is now where the GRACE score comes in. We call it risk stratification. So this is beyond you, but it was very good you brought it out. For ST segment elevation, you reperfuse urgently, either mechanically through PCI or you give thrombolysis. For the non-ST segment elevation acute coronary syndrome, you do your GRACE risk stratification. And for those patients who score very highly, it means you have to take to cath lab very urgently. So if I'm in Marsabit, I get such a patient, I stabilize the patient, I give aspirin, clopidogrel, all those things, but the patient has got ST segment elevation or Is NST segment elevation and subject them to gray score and is high, I'll tell them this patient needs to go to a place where there's cath lab. We need to look into the coronaries and look for an obstruction and resolve that obstruction. Now, finally, you monitor these patients for complications. Complications are extremely important, especially arrhythmias. So we divide them into arrhythmias, mechanical complication, and the other non-cardiac complications such as pericarditis. But the one which is very fatal, which can kill, is the ruptures, which you mentioned, ventricular rupture, ventricular ASD, etc., etc. 2, cardiogenic shock. 3, arrhythmias, especially ventricular tachycardia and ventricular fibrillation. And of course, acute mitral, papillary muscle rupture, which results in acute mitral regurgitation, as you rightly said. Now, as I summarize, I know time is flying. The take-home messages is one, especially, it's very rare for you to get a long case of chest pain. Generally, it has never happened unless, I don't know if it has happened in your time. But what you may get acute coronary syndrome mostly is in the OSCE stations, or if, let's say, you get a patient with heart failure and in the background you are taken through ECG and these kind of things. So when you're taking your history, just stick to the Socrates criteria. Always make a general impression of coronary syndrome rather than saying MI. Have a very good differential diagnosis, especially the life-threatening causes of acute chest pain. And when you are trying to investigate, whenever you investigate, say a reason. I will do full hemogram because I want to rule out if there's anemia, because anemia can cause angina. I wish to do creatinine UECs because cardiorenal syndrome, because I want to do contrast, whatever, angiograph for this patient, because this patient I suspect has hypertension, is also causing kidney disease, etc., etc. Electrolyte imbalances can also alter the ECG, etc. So whenever you are giving a reason, I mean a test, give a reason. I want to do an ECG because it will help me classify the acute coronary syndrome as either ST segment elevation or ST segment depression, whatever it is, and accordingly I manage, or it will affect my management. Echocardiogram, it's an important tool, but it's not an emergency tool, especially in acute coronary syndrome. It is definitely a test that needs to be done, but it's not as emergent, as important as ECG. Myocardial perfusion imaging, CT coronary angio, all those things are usually done. You are assessing patients who have got stable angina, which these days we call chronic coronary syndrome, and you want to see whether these guys will benefit from angiography or not. So it is called non-invasive assessment of ischemia. And there are very many. It includes CT coronary angio, it includes MRI, it includes stress echo, it includes exercise stress test, it includes myocardial perfusion imaging, but none of those are supposed to be done in acute coronary syndrome because they will not help, except for CT coronary angio. These days, CT coronary angio is used as a rule out to rule out the 3 most important life-threatening causes of acute chest pain. So if a patient comes to you with chest pain in accident emergency, you are not sure, is this PE, is it aortic dissection, is it coronary artery disease, then you can send for CT coronary angio and you just say triple rule out. What they will do is they will give a contrast, they will rule out aortic dissection, they will rule out coronary artery obstruction, and they will rule out PE. It's called triple rule out. So if the CT comes back negative, the troponin is negative, you can actually discharge that patient. So you can combine those 2 modalities, okay? Finally, there is a new concept of coronary artery disease called MINOCA, M-I-N-O-C-A. It means myocardial infarction non-obstructive coronary artery disease. In other words, this patient comes, very high troponins, echo is abnormal, everything is abnormal, ECG, you take them to cath lab, you put your contrast, the coronaries are normal. And there are very many causes. One of the most important differential is something called Takotsubo. And the classic history in MCQ is an elderly lady or whatever, she was breaking the news that her husband died or this happened. All of a sudden, she developed severe chest pain. ECG shows widespread ST segment elevation, but the coronaries are normal. So Takotsubo syndrome is a differential diagnosis. There is also something called microvascular disease, especially in diabetics. Recently, I had a lady, her ECG was abnormal, echo was abnormal. I was very pretty sure that she will have an obstructive coronary artery disease. Only to do coronary angio, it was perfectly normal. So always have that concept of INOCA at the back of your mind. As much as we always think of obstructive coronary artery disease, then there is also the non-obstructive, which can also give you or mimic a picture of as if the patient has got acute coronary syndrome. I think those are the few comments I will make, but this was an excellent discussion, and I congratulate both presenters.